Kenyatta National Hospital. So today, we're holding this webinar as part of our, remembering the World Hepatitis Day, which falls on the 28th of July every year. So why the 28th of July? We celebrate the person who discovered the hepatitis B virus and who later won a Nobel Peace Prize in medicine. He was a doctor from America by the name of Baruch Blumberg. And 2 years after discovering the virus, he developed the first hepatitis B vaccine. So we celebrate this day because we want to raise awareness on viral hepatitis and to step up our efforts in fighting this illness. It's actually a WHO target to eliminate viral hepatitis by 2030, and we just have 6 years to go. For each year, World Hepatitis Day, we have a slogan. And for this year, our slogan is, "It's time for action." And if we work together, we can eliminate hepatitis B. So for this webinar, you can post your questions on the chat, and Dr. Maritim will answer the questions at the end of the presentation. So I'll go ahead and introduce our presenter, who is Dr. Mary Beth Maritim, consultant physician and infectious disease / tropical medicine, travel medicine specialist, currently working as a senior lecturer in the Department of Clinical Medicine and Therapeutics at the University of Nairobi. She has over 17 years of clinical experience in case management of tropical and infectious diseases at KNH and Bagathi County Hospitals. She also has trained and supervised and mentored postgraduate and undergraduate students in this area. She's also working in the field of research and building healthcare capacity in the areas of advanced HIV disease and opportunistic infections. She also serves in several national advisory and technical committees within the Ministry of Health in Kenya, including NASCOP, where she's part of the Advanced HIV Disease Subcommittee and the HIV Guideline Review Committee. Thank you. Dr. Maritim, I hope you can hear me. Welcome. You can go ahead with your presentation. Dr. Maritim, you're muted.
Good afternoon. Let me just share my screen. Good afternoon. It's really a pleasure to be part of today's celebration. Just allow me to share my screen. Can you see my title screen?
Yes, I can see your screen, but yeah, now it's in presentation view. Yeah.
Oh, perfect.
Can
you hear me? Can you hear me?
Yes, loud and clear.
Okay, so thank you so much. And I'm grateful to the Ministry of Health, Dr. Nazila and team for inviting me to give this webinar on management of hepatitis B as part of the celebration for the hepatitis B day. So this is the outline of my presentation. We'll have a few case studies and then quickly look at the epidemiology, virology, transmission, and then look at the algorithm for the two cases, the 4 cases that I'll have discussed, just to put us into perspective in terms of how would we approach the various management and then have a conclusion. So I've provided a number of cases. And for these cases, I've focused on patients who are HIV negative. In the HIV space, when we have patients who have hepatitis B and HIV co-infection, the current first-line drug regimen that we use is able to take care of both infections. And therefore, the decision-making process would be at the point when you want to discontinue tenofovir as part of
I'm sorry, Dr. Maritim, you've dropped off.
Can you hear me?
Yes, now I can hear you, but I cannot see your presentation.
Okay, let me share the. So this is case 1, BA, a 29-year-old female who was seen at gestation, 13 weeks gestation by date, was a para 0 plus 1, reviewed at that time at the antenatal clinic, and she had brownish discharge and spotting 1 week prior to the review. She was otherwise well on dulfaston, 10 milligrams BD, and folic supplements. In terms of the medical history, she was known to be hepatitis B positive since 2019. She had a previous miscarriage at 8 weeks gestation by date, and an MVA was done. Past medical history, she had no history of admission, no past surgery, no known allergies. On examination, had a normal general exam, not pale, not jaundiced. Blood pressure was within normal. Heart rate was within normal, and abdominal exam showed a normal liver span. And at that time, the labs that were done, including the antenatal profile, revealed a blood group A positive, HIV non-reactive, VDRL non-reactive, and hepatitis B positive. Again, remember from 2019 up to the time when she was seen. So the liver function tests that were done are included there. And we want to focus on especially the AST and the ALT, which were 20 units per liter and were falling within the normal cutoffs for female. The bilirubins were within normal, and the total proteins again were within normal. Hepatitis B virus DNA was at 11,056 international units per mil, and this translated to 4.04 log units. So the question at that time was, would we start this patient on treatment for hepatitis B to prevent vertical transmission of hepatitis B, or do we need more information? If we were to make a decision to start, what would be the duration of therapy? And in the end, the gyne team started on prophylaxis of tenofovir combined with lamivudine. This is the current regimen that we have within our CCCs. We don't have tenofovir existing on its own. So we have a combination of tenofovir with lamivudine, and this is what was given. Case 2 is a 26-year-old female who presented at 32 weeks gestation to the ANC clinic, found to be hepatitis B positive. Again, she's otherwise well and the baby is well. She's HIV negative, and the doctor recommends a test for hepatitis B DNA levels, but she's unable to afford the test. She's advised to ask relatives to help raise money for the test. Should the doctor go ahead and offer antiviral treatment anyway to prevent transmission? And then the question would be, for how long will they have to treat this mother? Case number 3 is a 28-year-old female, again presented, this time in labor ward, in active labor. The ANC profile is done, and she's found to be hepatitis B positive. She's HIV negative. On assessment, she's well. has no stigmata of chronic liver disease. She proceeds to deliver a live female infant. Both mother and baby are well. The gynae team consults on what to give the baby for hepatitis B prophylaxis and whether the mother will need treatment now that she'll be breastfeeding her child. Hepatitis B vaccine is administered at birth for the infant, and the ID team recommends hepatitis B immunoglobulin administration. This case number 4 is a 25-year-old male, a Gen Z, who came to donate blood recently when we've had the demos. So at that time when he presented, he was essentially well, and screening tests that were done revealed HIV. This is part of screening the blood for transfusion. HIV negative, hepatitis C negative, VDRL negative, but hepatitis B surface antigen is found to be positive. So he's been referred to us for further workup and management. He's otherwise well, has no complaints, no comorbidities. He drinks alcohol, but occasionally because he's currently also unemployed. So on further history, he's not aware if he received any hepatitis B vaccine as part of the childhood schedule. But what we know in country is that the National Immunization Program started offering hepatitis B vaccine in 2002. So it's unlikely that he received the vaccines at that time because he was born earlier than the time when the vaccines were being rolled out. He's currently unemployed. He's not able to afford too many tests. So some of the tests, the investigations of the tests that were done, HB was 14 grams per deciliter, white cell count was within normal, platelet counts were lower limit of normal at 150,000. And LFTs, the ALT was 45 units per liter and AST 135 units per liter. I've underlined this test because we'll need them in the next slide in terms of decision making. Are there some non-invasive tests that can help us in terms of decision making? And we'll speak about them as we go through the algorithm. So important is the platelet count, the ALT and the AST, and the age of the patient, which is 25. Yeah, so how will we go about the decision to treat or not to treat this patient? Case number 4. So for case number 4, there's a new non-invasive test that's been proposed in the latest WHO guidelines that is useful and has been validated as a non-invasive decision tool that can help in terms of deciding which patients may benefit from treatment. So the AST to platelet ratio index has a calculator. And for this particular patient, when I use the calculator, I was able to get, given the AST was 136, so in this, it's a ratio between the AST and platelet. So AST is 136 divided by 40, and then all this is divided by the platelet count 150, and this gives a ratio multiplied by 100, and this gives 2.267. So an APRI score less than 0.5 has a negative predictive value. It's able to rule out cirrhosis. But if it's greater than 0.5, then it suggests that there's cirrhosis, and we'll look at it when we go down the algorithm. So for this patient, despite the fact that this liver transaminases did not look markedly elevated, the APRI score was quite high. Then the next non-invasive tool is called FIB4. And basically, there's also a calculator for this. So for the calculator, you need the age of the patient, you need the AST, which is 136, you need the platelet count, and then the square root of the ALT. So the ALT was much lower than the AST is 45. And when you calculate his FIB4 score, you actually get 3.38. So a FIB score less than 1.45 has a negative predictive value to rule out advanced fibrosis. So in this case, his score was 3.38. And what that means is that a score of more than 3.25 has a very high predictive value for advanced fibrosis. So despite the fact that our case 4 was diagnosed to be hepatitis B positive as part of screening, we are able to use non-invasive tests and actually estimate his score. And it will not be surprising that his scores are high, and we'll be talking about it as we go along. When you look at prevalent cases of chronic hepatitis B, majority of cases for hepatitis B actually found in the Africa region and Southeast Asia region. That's where the biggest burden of hepatitis B, chronic hepatitis B, is found. And as part of the elimination goal, there's really a refocus now to try and significantly reduce the burden in these particular regions and any other region that is affected. For us in sub-Saharan Africa, when we look at the burden of chronic hepatitis B, it's more or less similar also to our high burden of HIV. And that's why even when you're looking at the treatment, first-line treatment regimens, they're able to target both infections. But the concern is for people who are HIV negative, then tackling hepatitis B is even of a more significant concern. So when you look at the top 10 or so countries, 2/3 of the global disease burden actually occurs in these countries. So China is leading, India, and then in Africa, Nigeria, Ethiopia are quite high there. So although Kenya is not part of these statistics, prevalence is significantly high. And therefore, even as we have our World Hepatitis Day, it's just to renew the focus on hepatitis B. This is data for the HIV prevalence. And when we look at this HIV prevalence, again, sub-Saharan Africa is leading in terms of HIV prevalence, and therefore the dual infection contributes a significant morbidity. And we are grateful that the first-line regimens that we use for HIV are able to tackle hepatitis B that may coexist or may be a comorbidity in our patients. So this is the structure of hepatitis B virus, and it's a DNA enveloped DNA virus. And when you have infection, you can have acute infection or chronic infection. And definition for acute infection is up to 24 weeks. So 6 months is the definition of acuteness. And then beyond persistence of infection, beyond 6 months is considered chronic infection. People can present with a symptomatic infection, mild disease, severe disease, or even rarely fulminant hepatitis. So the case 4 that we've looked at just now is actually one of asymptomatic infection, because the patient did not even know that he was infected with hepatitis. And majority of people are actually walking around and they do not know that they are infected. So screening is very, very important. Acute hepatitis B is a self-limiting disease. It has a fairly low case fatality rate, just about 1%. Chronic hepatitis B, we've already talked about the definition and its persistence of hepatitis B surface antigen beyond 6 months, and it would have a spectrum of diseases. So age of exposure is a key factor in determining the risk of chronic infection. So most people who acquire hepatitis B infection in childhood have a predisposition to chronicity. And for this 25-year-old case 4, most likely could have gotten infected as a child. And that's why it has persisted in his body and is presenting now without even knowing that he was infected. In the structure of the hepatitis B, there are various different antigens, and these antigens are important in terms of structural functions for the virus, but also for us are important in terms of diagnostics. We have the hepatitis B surface antigen, the core antigen again, which is found in the liver, because following infection, the virus integrates within the hepatocytes within the host. And therefore, if you want to assess for the core antigen, you have to undertake a liver biopsy. Then we have the E antigen, which would be found within the blood and is a marker for infectivity. So we have these various antigens, and I don't want to spend too much time explaining them, but surface antigen would be positive and it's a marker of infection, which can be acute. And even when it persists beyond 6 months, then it's a marker for chronicity. The E antigen appears at the onset of symptoms and indicates viral replication. Then we have various antibodies. Hepatitis B core IgM antibodies is a marker of recent infection. And therefore, if you find it, we have used it in the past to determine whether when you're meeting the patient and they have hepatitis B surface antigen, if you do the IgM and you find it positive, it suggests recent infection. The core IgG is a marker of either vaccination or prior exposure or contact with the virus. The E antibodies appears at the point of disappearance of the E antigen. And then anti-hepatitis B surface antibodies appear 3 months, 1 to 3 months after hepatitis B vaccination. So in terms of interpreting these various antigens and antibodies, it gives you a sense in terms of where the patient is. Sometimes it's very expensive to do a lot of these markers. And that's why in terms of decision making, a lot of shift now is focusing on other non-invasive criteria that can be used in terms of clinical assessment of the patient. This is not new to us in terms of transmission for hepatitis B. You can get hepatitis B through percutaneous or mucosal exposure to infected blood and body fluids. You can also get through accidental inoculation of minute amounts of blood or fluid during medical, surgical, and dental procedures. And that's why following post-exposure, you have to do a certain like there's a protocol for managing exposures. And then sharp objects contaminated with infected blood, inadequately sterilized syringes and needles, which used to be a factor back in the days when we didn't have proper infection prevention and control strategies and people were reusing some of the clinical syringes. But this is important, particularly in our key populations among people who inject drugs, because sometimes they share syringes and needles, and therefore they can get infected in that process if they share a needle with someone who's hepatitis B positive. Intravenous and percutaneous drug abuse, again, mediated through contaminated syringes and needles, and then tattooing, body piercing, acupuncture, and sexual transmission. Vertical transmission, mother-to-child transmission, is particularly important in our setting. And this is because we screen for hepatitis B in pregnancy, and sometimes we don't offer an intervention to the mothers who screen positive. And even around the peripartum period, we do not currently offer a birth dose for hepatitis B to reduce the risk of the baby getting infected. There is a role for immunoglobulin, but again, they are not readily available and therefore may not be available to majority of our mothers who even screen positive. So the greatest risk for developing chronic infection is 90% following mother-to-child transmission. And this is up to a period of 6 months. For a mother who's infected, that risk of infecting the baby persists up to 6 months of age of the baby, but decreases to about 30% between the ages of 6 months to 5 years. So mothers seropositive for E antigen and who have a high hepatitis B viral DNA in blood, so more than 200,000 international units, are at high risk of transmitting the infection to their infants in the absence of prophylaxis. So this is really, really important because we can do something about it. We can actually break that cycle of transmission, and particularly because we are saying that majority of children who get infected in the first 6 months of their life are likely 90% of them will persist to chronicity. So this provides us an opportunity to really break the cycle of transmission. Although hepatitis B vaccine can infect the fetus in utero, this is rare, and transmission is generally associated with the antepartum, hemorrhage, and placental tears, anything that will increase the blood coming into contact with the baby. So this also is able to explain how hepatitis B clusters within family groups, because when you have an infected family member, they're likely to transmit the infection to other members within the family. So I put this slide here just to tell us about the non-invasive test to assess liver fibrosis, and one of them is the APRI score. So for this test, you actually need to measure the aspartate aminotransferase as well as the platelet count, and it's affordable because these tests are readily available to us. For FIB4 score, you need, so it's a fibrosis 4. So you're looking at 4 parameters: the age, the aspartate aminotransferase, the alanine aminotransferase, and then the platelets. Again, these are tests that are readily available to us. And then FibroScan requires a dedicated equipment. It's a specialized ultrasound that's able to assess the fibrosis within the liver. So this one is much costlier because you require dedicated equipment, but the first two are readily available to our patients. So clinical features of advanced liver disease and cirrhosis And this will be important when you go through the algorithm, because one of the criteria is that you would need to make a decision whether to treat the patient based on whether they have advanced liver disease or features of cirrhosis. So features of advanced liver disease and cirrhosis would include things like hepatomegaly, splenomegaly, which can be able to identify clinically, presence of pruritus, presence of fatigue, arthralgia, palmar-erythema, as well as edema. So the lack of oncotic pressure because of impaired liver synthetic function would manifest as edema. So this is in addition to history taking. You'll be looking for these clinical features. Clinical features of decompensated cirrhosis, again, which is advanced form of cirrhosis, is where you have portal hypertension. And for you to say a patient has portal hypertension, you want to demonstrate ascites, evidence of variceal hemorrhage, as well as hepatic encephalopathy. They may not have all this at the same time, but may have one or the other, which would help you to say that they have portal hypertension. But remember, again, there may be other causes of portal hypertension in our setting that may not necessarily be related to hepatitis B. So again, the history is very important, and confirmation of hepatitis B, then presence of this additional clinical features. Presence of coagulopathy, again, is a marker of decompensated cirrhosis, and then liver insufficiency, where they may manifest with jaundice. So jaundice usually would present clinical, maybe at the onset, but may not necessarily be present at the time when you're meeting the patient, particularly because the patient may have a long history of living with the hepatitis B virus. We have different stages of liver fibrosis, and this scale, the Metavir staging, has 5 scales from F0, F1, F2, F3, and F4, where F4 is cirrhosis, F0 is no fibrosis, and then F1 is portal fibrosis without septum, F2 is portal fibrosis with septum, F3 is numerous septa without cirrhosis, and then F4 is cirrhosis. So normally when you're looking at the APRI score, your APRI score will most often correspond to F2, which is portal fibrosis with septum, and then your FIB score is likely going to correspond to F4, which is cirrhosis, like the terminal phase of cirrhosis. So this is the APRI score, and for the patient, I actually calculated. So for the APRI score, it's your AST divided by the upper limit of normal. And in most cases, the upper limit of normal, you would use the upper limit of normal based on the lab where the result was undertaken. But on average, we always use an estimated upper limit of normal for both AST and ALT of 40 units per liter. And then this is divided by the platelet count and then multiplied by 100. And that gives you, it's easier when you use the calculator, which is available online on the links that are provided within the slide. For the FIB score, what you need for that, you need the age in years, you need the AST, again in international units per liter, and this is divided by the platelet count, where you're talking of the platelet count. So the number multiplied 10 to the power 9. So if it's 250,000, you'll use the 250, and then your ALT in international units per liter. So most of these are actually available because when patients come to the hospital, we're able to do the blood count, and we're able to do even the liver function test. So we are able to get these parameters, and it makes it easier for us to be able to make a decision regarding the patients that we are looking after. So coming now to the algorithm for assessment, treatment, and monitoring people with chronic hepatitis B. And this is really a very simplified algorithm, part of the WHO 2024 chronic hepatitis B guidelines, which is a revision of the 2015 guidelines that's looking at simplifying the management of patients and even helping in terms of decision making, with consideration that many people who live in the highest burden settings, particularly Sub-Saharan Africa, Southeast Asia, may not have enough resources to undertake some of the recommended tests in the previous guidelines. So the first step in the initial assessment is you have to determine the hepatitis B surface antigen status, which is a marker of the infection. So based on that, you want to do 2 things. First is to assess for treatment eligibility. And then the second thing is to assess for general care measures and counsel the patient on general care measures. So within the assessment for treatment eligibility, you want to assess for severity of liver disease, and you want to use a non-invasive test, the aspartate platelet ratio index, which we've already talked about, the APRI score. And then you also may do the transient elastography. So it may be one or the other. So you can estimate the APRI score to be able to judge whether the patient has, on the METAVIR score, whether they have F0 all the way to F4. You also want to determine the ALT and the hepatitis B DNA level. You want to obtain the medical history. So in the medical history, you're screening for co-infections such as HIV, hepatitis D, and hepatitis C virus. So hepatitis D virus is a virus that superinfects people who already have hepatitis B viral infection. So it's a defective virus because it can only infect and cause co-infection in people with pre-existing hepatitis B. And the presence of D, the superinfection of D on B causes worsening and shortens the time to cirrhosis. Hepatitis C, again, is a RNA virus, affects the liver, and therefore the risk for cirrhosis is increased when you have the two co-infections. Other comorbidities that are important include diabetes and steatotic liver disease, immunosuppression, such as patients who are on long-term steroids, transplant, and then extrahepatic manifestations such as glomerulonephritis, vasculitis, or family history of liver cancer or cirrhosis. So this is an exhaustive medical history, and we'll see in the next part of the algorithm that once you've taken the detailed medical history, then you're really able to make a judgment in terms of how will you approach the management of the patient. And some of these comorbidities, the consideration for giving them importance is that in patients who have immunosuppression in the presence of hepatitis B, they can actually have reactivation of the disease, which can result in fulminant hepatic failure. In terms of general care measures, counseling on lifestyle such as alcohol consumption, diet and physical activity, and then preparation for starting treatment such as adherence support, risk factors for renal dysfunction, and baseline renal function. So we need to assess the renal function because when you're using tenofovir, one of the effects is that it can affect the kidney as a side effect. So you want to assess for renal dysfunction. When you're treating again hepatitis B, the treatment is for life, and therefore your adherence support is very, very important to prepare the patient for lifetime treatment. Then preventive measures such as hepatitis B surface antigen screening of family and household members and sexual contacts with hepatitis B vaccination of those negative. And this is important because you've said hepatitis B clusters around families. So you've already done the eligibility. You've done the initial assessment. The next step is treatment eligibility. And we have this algorithm that really guides us. So we are going to offer treatment to all adults and adolescents. And the cutoff for children is 12 years and older. And this would also include pregnant and non-pregnant women, as well as girls of reproductive age. And the consideration for treatment is not that you have to have all the criteria. So in the first box, we're looking at presence of significant fibrosis. So if we have a score greater than F2 on the METAVIR score, which was the cirrhosis with septin, that's greater than F2, or cirrhosis, presence of cirrhosis, regardless of your hepatitis B viral DNA or ALT levels. And for this one, you're using a clinical criteria for cirrhosis, which we already discussed, where you're looking for features of advanced liver disease clinically or features of cirrhosis clinically. And then presence of non-invasive tests, an APRI score greater than 0.5 or transient elastography greater than 7 kilopascals per adult. So back to our case 4, the young man who came asymptomatic. If we look at his APRI score, it was actually 2.2 something. So already based on the APRI score, he actually qualifies to be treated because for this, it is based on clinical presence of cirrhosis or evidence of fibrosis or non-invasive tests. So based on the non-invasive test, that young man actually qualifies to receive treatment. So that is one consideration, presence of fibrosis. Or the second consideration is if your patient is able to afford and you're able to do the hepatitis B viral DNA, and you find that your copies are 2,000 international units per mil, and the ALT levels are greater than upper limit of normal. This criteria will make you offer the patient treatment. So that is a second consideration. The third consideration is presence of any of the following comorbidities, regardless of the APRI score or the hepatitis B DNA. So the third criteria is regardless of criteria 2 and 3, and that is presence of co-infection. Like if the person has HIV, you have to offer them treatment. If they are co-infected with hepatitis D virus, you have to offer them treatment. If they are co-infected with hepatitis C, you have to offer them treatment. If they have hepatitis B and family history of liver cancer or cirrhosis, you have to offer treatment. If they have immunosuppression and hepatitis B, you have to offer them treatment. If they have comorbidities like diabetes and hepatitis B, or hepatitis B with metabolic dysfunction associated steatotic liver disease, they qualify for treatment. And then if they have hepatitis B and extra hepatic manifestations of hepatitis B, such as glomerulonephritis or vasculitis, then you have to offer them treatment. And then the last criteria, in the absence of hepatitis B viral DNA assay, patients who present with persistently abnormal ALT levels alone. So it means you have to monitor the ALT levels and see if they are elevated, then they'll qualify for treatment. So if your client has any of these criteria 1, 2, 3, or 4, remember they are not additive. Each of them is independent. That's why they are connected with or. Then you'll be able to justify initiating them on treatment. However, if they don't have any of those, like if they have ALT that is normal, the DNA levels you have been able to quantify and is less than 2,000, they don't have any co-infection, then for these clients, you defer treatment, but you'll keep monitoring them and we'll be able to see how you monitor them. So you've already made a decision, like for the young man, and you now want to offer them treatment. What will you initiate? So the recommended treatment is to initiate antiviral therapy, and we'll be monitoring. So the first line recommended treatment is tenofovir, and you can use tenofovir or you can use etravirine. In our setting, etravirine is not easily available, so we end up using tenofovir. However, we don't have tenofovir existing on its own, so we resort to using this combination treatment because we don't have TDF monotherapy within our HIV programs currently. So TDF combination with lamivudine. So TDF is tenofovir, disoproxil fumarate, and then 3TC is lamivudine. And then you can also use tenofovir, disoproxil fumarate plus emtricitabine. Again, this is available. We use this drug for HIV pre-exposure prophylaxis. The other drug is etravirine. You can use monoformulated etravirine or tenofovir alafenamide fumarate. And these two drugs are useful in people with osteoporosis or who have impaired kidney function. Again, also useful in children and adolescents. The only caveat is that TAF currently is licensed for adolescents from the age group 12 years and older. So you cannot use it in the younger population. The evidence is still awaited for that younger population. So the difference between TDF and TAF, TDF both of them are prodrugs of tenofovir, but TDF acts mainly, is a prodrug, and most of the drug exists extracellularly. And therefore, when it's given as 300 milligrams, which we use for the HIV and would be in the co-formulated formulation, then you'll find that you have extra drugs that is not necessarily exerting effect where it's required. But TAF is given at 25 milligrams. Most of it enters the cell and therefore acts intracellularly and has less toxicity because you don't have a lot of drug in the extracellular space. In terms of monitoring, you'd need to monitor clients for persons with cirrhosis and family history of liver cancer. You need follow-up and monitoring every 6 months, and you'll be using alpha-fetoprotein and ultrasound as part of surveillance because you're looking out for development of hepatocellular carcinoma. For other patients, then you'd monitor them every year. So you're looking at treatment response or even disease progression, and you'll be looking at adherence at each visit, even on treatment. And then non-invasive tests such as the APRI, whether the APRI is improving. You could also do the transient elastography, and then also monitor with ALT and hepatitis B viral DNA level. But you'll also need to monitor the renal function to see, because the drugs that you're using could have an impact on the renal function, and there's a way you'd need to adjust the renal doses depending on declining renal function. For the pregnant woman, I will be presenting on the algorithm, which is slightly different, and this is with relation to preventing using the existing antiviral prophylaxis for prevention of mother-to-child transmission in pregnant women and adolescents with chronic hepatitis B, and then assessment of treatment eligibility for their own health. So we have two categories. There will be mothers who would require the prophylaxis to prevent mother-child transmission, but there'll also be mothers who would require the treatment based on their own health, where they qualify for treatment for hepatitis B. And this is a frequently asked question because we currently are screening in the antenatal clinics, and therefore we need to have sort of standardized approach in terms of preventing the risk of transmission to the mothers. So in terms of serological testing, hepatitis B surface antigen testing in pregnant women, again, is recommended using a rapid diagnostic test or even the laboratory-based immunoassay. And you can end up with two results, either hepatitis B surface antigen positive or hepatitis B surface antigen negative. And then once you have your result, then you're going to assess. For the mothers who are positive, you're going to make an assessment of eligibility for antiviral prophylaxis. So you'll assess for antiviral prophylaxis, but also you'll be assessing for maternal intervention in terms of antiviral prophylaxis. So in terms of antiviral prophylaxis, you would need to do the hepatitis B viral DNA or the e antigen testing. Remember, e antigen, when it's positive, it's a marker of infectivity, and the risk for transmission is much higher for those mothers who are e antigen positive. So the current guideline is very cognizant that in many countries in sub-Saharan Africa, we may not have programs that are able to support screening of all the mothers. And therefore, we have on the right side of the algorithm that where this DNA testing and e antigen testing is not available, then the decision would be to offer maternal tenofovir prophylaxis to all hepatitis B surface antigen pregnant women and adolescents. So it means you have to have screened them, and if they're positive, then you offer tenofovir prophylaxis because you're not able to make judgment in terms of the magnitude of the DNA, quantify it, and even the e antigen positive. Where you're able to do your DNA quantification and e antigen testing, then you would need to assess. So if your hepatitis B viral DNA is less than 200,000 international units and your e antigen is negative, then there's no need for maternal tenofovir prophylaxis because the risk for mother-child transmission is low. If your hepatitis B viral DNA is greater than 200 international units per mil, or your e antigen is positive. Sorry, I think for the first one I said and. So each of these is independent. So you're looking at the viral load DNA. If it's greater than 200,000 or your e antigen is positive, then you need to start maternal tenofovir prophylaxis. And the recommended guidance is to start from the second trimester of pregnancy until after delivery. So when the guideline has recommended 28 weeks pregnancy up to 12 weeks post-delivery. So in that period, you're actually able to reduce the viral load from the 200,000 to undetectable levels, and therefore you reduce the risk of transmission to the baby. So in our setting, because we don't currently have these diagnostics readily available, then it means we are really guided to offer tenofovir prophylaxis to all the pregnant mothers until we're able to maybe make judgments. So looking at our different cases that we started off with, there was one case where we did not recommend prophylaxis because the DNA levels were quite low. But if we were to revise that case now, and maybe the mother, there was one mother who could not afford to do the DNA levels, then we could have offered the mother the prophylaxis. So it doesn't stop here. The algorithm continues. You want to assess the mother again for eligibility, and this is related to the previous guideline, where the mother may have certain indications where they actually require the hepatitis B treatment for their own disease progression, to avert disease progression. So this is very similar to the algorithm that we had seen earlier for the HIV negative non-pregnant individuals. So if they have significant fibrosis, using the non-invasive tests, regardless of the hepatitis B viral load DNA or ALT levels, or if they have hepatitis B viral DNA, more than 2,000 international units and an ALT that is higher than the upper limit of normal, or if they have comorbidities that we already talked about, co-infections, family history, immunosuppressions, comorbidities, and then extrahepatic manifestations, and then persistently abnormal ALT levels alone, even in the absence of hepatitis B DNA viral load. Then if they have these indications, what this means is that the mother will require the treatment for the hepatitis, and therefore it means you will not be giving prophylaxis, because the prophylaxis is for a defined period of time, from 28 weeks to 12 weeks postpartum. For this one, the treatment of the mother will have to continue. You'll start now, and it will be lifelong up to the point, even after delivery, they'll have to continue the treatment for hepatitis B. So in conclusion, we've looked at the epidemiology of hepatitis B. We've looked at the algorithm for both adults and adolescents. We've looked at the algorithm in pregnancy. And therefore, what this means is that with the new guidelines, and I know in the national space, there's discussion in terms of updating the existing hepatitis B guidelines. The current WHO guidelines actually simplify the decision-making for healthcare workers and makes it easier in terms of enabling a lot of people who qualify for treatment to actually be able to access the treatment. So I think one of the things I forgot to mention here, so when you make the decision in terms of providing the prophylaxis for the mother, you also have to prepare for the delivery of the baby. And one of the current gaps that we exist is providing the birth dose. So we currently have hepatitis B vaccine that's offered to children, but 6 weeks, 10 weeks, and 14 weeks. And the birth dose is available. The only challenge is that for the birth dose, it's a monovalent hepatitis B vaccine. The current existing hepatitis B is actually part of the pentavalent. So it's 5 antigens together. And I know the immunization program is working towards availing a birth dose in the public sector, because it would really be a game changer, because you'll be offering the mother's prophylaxis, but also offering an intervention to the baby to prevent transmission. And the birth dose is important because when you give the baby the birth dose, then they are able to develop antibodies within 7, 14 days. And therefore, even by the time you're coming for the first hepatitis B vaccine at 10 weeks, and the mother is taking prophylaxis up to 12 weeks, then you're able to actually cover for that particular period, because we talked about the risk of transmission being highest from delivery to 6 months in the postnatal period. So allow me to stop there, and I'll be available to take questions. Thank you very much.
Thank you, Dr. Maritim, for that great presentation. Thank you. And the audience has also appreciated. They've been sending a lot of emojis with thumbs up. So there are quite a number of questions on the chat. So we can just go straight to the Q&A. Yeah. So there's a question here. The first question is from Henry Wanyama, who is asking, he has a patient with advanced hepatocellular carcinoma and or decompensated chronic liver failure with a Child-Pugh class C. Is there any benefit of treating that patient for Hep B in view of the short survival from the complications?
So I think you have to weigh risk versus the benefit. So like we said, the current treatment can be able to retard the progression of the fibrosis, but in a patient who already has hepatocellular carcinoma and it's already advanced, chances are this patient even has other comorbidities such as renal disease, and therefore the benefits from the drugs may not really be there because you will not be able to reverse the hepatocellular carcinoma, you'll not be able to retard the growth, and you're likely to worsen even the renal toxicity. So in this particular patient, there's actually no benefit from treating the patient with the current antiviral therapy. If the patient just had decompensated chronic liver disease without the hepatocellular carcinoma, there would still be benefit for treating the hepatitis B. But in the current state of this patient and the short survival that you've even alluded to, there's actually no benefit the patient will derive from the hepatitis B treatment, and it may actually be more harmful than beneficial.
Okay, the next question is about the duration of therapy for hepatitis B. So how long do you treat? Yeah.
So for this treatment, like I've said, you treat for life. Because when you've already assessed the patient and they need the treatment, then you have to treat for life. When you interrupt the treatment in people who have hepatitis B, they can actually have a fatal flare. They can have resurgence of the disease because of interrupted treatment. So the decision to treat and also the adherence counseling is actually because the duration of treatment is for life. So that treatment has to be taken for life.
Okay, so there's another related question here, asking a similar thing. So any role for drug holidays? I think for those patients who are stable on chronic suppressive therapy, is there any criteria for interrupting therapy?
So I've not come across a situation where a patient who's taking treatment can actually interrupt the treatment and be off the treatment. But I think from most of the evidence, and even when you look at the guidelines, so within the guidelines, they actually look at the evidence that they've adduced to inform the guidelines. And in most of the recommendations, most of the patients were actually taking treatment for life. So there was once a patient, when we were on rotation, we were on an elective rotation. We had a patient who had been taking HIV treatment that had tenofovir, lamivudine, and efavirenz for HIV and hepatitis B. So when he came, he wasn't able, when he migrated to the US, his treatment was interrupted. And actually how we came across the patient, he was actually on the transplant list because the interruption of treatment worsened his hepatitis B disease, and he developed fulminant hepatic failure, whose treatment was now liver transplant. So I'm not sure that we have enough evidence to recommend drug holidays for our patients. And I think this is an area that is worth studying to see, because when you look at the pathogenesis of the disease, there are many things that are able to control the hepatitis B infection, in addition to the drugs that you'll be giving. And sometimes even the flare-up can be the host immune response to the presence of the virus. So at this point, I haven't come across literature that recommends drug holidays or interrupted treatment. And from experience, it may actually be more harmful to the patient to interrupt that treatment, because then you have hepatitis B that is replicating without any control, and this causes the fulminant hepatic failure. So currently, no drug holidays.
Okay, so there's a question about the scoring systems that you presented. So someone is asking whether they are specific to hepatitis B or they can use them in other causes of liver disease, like alcoholic liver disease.
So I've come across them with regard to hepatitis B, but I'd have to check whether they're useful for other forms of alcoholic liver disease. So that one, I'll have to look up the answer for that, whether they're useful. And maybe if we have a hepatologist in the audience, maybe they can guide in terms of that. But for the WHO evidence grading, they were specific for hepatitis B in terms of determining the fibrosis. So I'd have to look up whether they're useful for other forms, such as even alcoholic liver disease.
Okay. So someone is asking, what happens if you get vaccinated for hepatitis B in the past, and then can you get infected again without knowing it?
No, I think the person is asking, for example, if you're already infected with hepatitis B and then you receive a vaccine, what will happen? Because that's how they've written. What happens if you get vaccinated and you're infected without knowing? So I think the infection is pre-existing and then you get vaccinated, just like the way we do for our medical students. When they come to the clinical area, they receive a vaccine, but we never test them to see if they are hepatitis B surface antigen positive. So in such a case, because you're already infected, the vaccine will not benefit you because the vaccine is supposed to develop antibodies to protect you from the infection. So in the presence of an existing infection, the vaccine cannot reverse the effect, and therefore your infection will still persist. The vaccine will have no consequence because you already have the existing infection.
Okay. So there's a question here on one of the serious side effects of tenofovir is liver damage. Hepatitis B also damages the liver. So they are asking, why is TDF recommended in Hep B infection?
So let me just correct. I think TDF causes renal damage. It doesn't really cause liver damage. It's excreted in the kidney. It's nephrotoxic. So it doesn't really cause liver damage. So just to correct that, that it causes renal damage rather than liver damage. And that's why it's used to treat hepatitis, because it's active against, it's an active antiviral for hepatitis.
Okay, thanks for that clarification. So there's a question here, which I don't know whether you'd be able to answer because they're asking at MOH level. So they're saying at MOH level, most of the facilities lack diagnostic capability for hepatitis B. So they're asking, what measures might you be putting in place to help to solve that?
I don't know that Dr. Nazila from MOH is here. She may be able to answer that, but I don't see her in the audience. So currently, maybe I can just attempt to answer. The Ministry of Health through NASCOP has established working group, technical working group for viral hepatitis. So it's broadly viral hepatitis, or which hepatitis B is there, hepatitis C is there, and even sexually transmitted infection. So one of the terms of reference for the working group will really be to address some of these issues around diagnostics, therapeutics, management, So I think this will be addressed once the working group convenes. And currently, there's a process even to update the guidelines. So I think the ministry is doing a lot to try and address the lack of diagnostics. So this will include even providing guidance in terms of what are the diagnostics? Are they rapid diagnostic tests? Are they lab-based assays? So this is work in progress. And hopefully when we meet for the next World Hepatitis Day next year, we will probably be presenting a different picture, because you'll be feeling it on the ground in terms of diagnostics and guidance in terms of what would be available.
Okay, so there's a question here. What confers higher transmission, breastfeeding or antepartum hemorrhage or the placental tears?
So the antepartum hemorrhage, the peripartum period, because the amount of volume of blood that is available confers a higher risk compared to even the breastfeeding. So it's around the peripartum period, and that's why the strategies now are focusing around reducing the maternal viral load, because it's the virus that is able to cross the placenta and be able to cause the infection. And then also providing the baby with a birth dose of the vaccine and even immunoglobulin where it's available. So there's a shift even from blanket recommendation for the immunoglobulin because it's not readily available. So the two most important interventions is tenofovir prophylaxis for the mother and then the hepatitis B birth dose for the baby. But prompt tenofovir can reduce the viral load significantly and reduce the risk of transmission. And remember, another thing, even when you're giving the tenofovir, is for 12 weeks, because once you have the viral load reduced, you want to maintain that it's reduced up to the point when the baby's immunity, like when they receive the first dose of pentavalent, which has hepatitis B, then they are able to develop their own antibodies. So those interventions together are able to reduce that risk.
Okay. So there is this question about who are at high risk of contracting hepatitis B.
Everyone who's in contact with a person who's infected is at high risk. And that's why I emphasize the modes of transmission. If you're a healthcare worker, you could get occupational exposure. And that's why vaccination of healthcare worker is an important component. But other groups, high-risk groups, would be people who inject drugs, people who come into contact with like children born to hepatitis B mother. So everyone is at risk of contracting hepatitis B, so long as you're exposed to a hepatitis B positive person. And we've already talked about the modes of transmission.
Okay. There's a question here about the scoring systems. So someone is asking, between FIB4 and APRI, which is more sensitive and higher reproducibility?
So I haven't come across that literature in terms of one being preferred over the other, but because they are both non-invasive, remember your APRI is looking at your AST and your platelet. Your FIB4 will also have the platelets, it will have your age, it will have AST and ALT. So they are more or less the same, but I think we can look at the literature to see which one is more sensitive. But my recommendation is that for your patient, you need to estimate both where possible, because these tests are readily what we ask for in our clinical areas. So we should be able to estimate for each of our clients who are hepatitis B surface antigen positive, their APRI and FIB4 score.
So there's this question about the liver cirrhosis. So does a family history of alcoholic liver cirrhosis also qualify one for treatment?
No, because I don't know, family history of alcoholic liver cirrhosis. So you like, I don't know, understand this question. If someone has a family history of alcoholic liver cirrhosis, like if my father was drinking alcohol and he got liver cirrhosis, for you to have the same risk, you have to be drinking the alcohol. It's not genetic transmission. So for this one, I think it would have to be other causes of liver cirrhosis, where you're talking about things that could have a genetic basis. Some of those liver diseases where maybe you're lacking a certain enzyme, or you have a predisposition because of certain toxins that you may be exposed, but not alcoholic, family history of alcoholic liver cirrhosis. Unless you're the one taking the alcohol, then that puts you at risk.
Okay. So the next question, should we initiate treatment in an 85-year-old if they qualify all the criteria that we've mentioned above? Are there age cutoff?
No, there are no age cutoff. So you're looking at this 85-year-old and thinking that maybe they're about to die, because in Kenya, maybe life expectancy is 65 years and all that. But you have to still make a judgment on an individual basis. So for this patient, the only precaution is that if they qualify for treatment, you'd have to rationalize what agent you're going to use because of the underlying renal disease. Because as people age, their kidney function also deteriorates. So this is a patient who would benefit maybe from entecavir or tenofovir alafenamide fumarate, as opposed to TDF, because also of the effect on bone disease. So this patient would qualify for treatment if they meet the criteria. The issue now will be judgment based on what treatment specifically you're going to give him because of his age and maybe other existing comorbidities, in which case now you're worried about existing osteoporosis and existing like renal impairment just by virtue of his age.
Okay, the next question. So this is like a clinical vignette. Someone Someone says they have a 50-year-old with end-stage renal disease, is HIV positive, is on anti-TBs and is MIA positive for TB for the past 1 month. So the patient tested positive for hepatitis B surface antigen. They have started hemodialysis for that end-stage renal disease. And for this reason, the clinician has had to stop TDF and change to ABC, 3TC, DTG. Is this sufficient, this regimen sufficient for his HBV treatment?
Oh, so just repeat again. The patient has co-infection, HIV and hepatitis B, but now has end-stage renal whatever, and then anti-TBs.
Yeah. It's on anti-TB treatment as well, yes.
Do we know what's causing the end-stage renal disease? Was it the TDF?
Okay, they haven't indicated, but I think the clinician just felt, they haven't written that.
Okay, so the most important thing, yeah, so because they have end-stage renal disease, it means the GFR is less than 15. So for both even TDF and TAF, it's not wise to use them when the TDF is quite low like that. But the fact that the patient is now on renal replacement therapy, then you might be able to work around even giving maybe once a week dosing of TDF. In the absence of that, then this patient would benefit maybe from a drug like entecavir, because if you don't treat the hepatitis B, actually when you interrupt the treatment abruptly, like has happened in that case, then you can have fulminant hepatic failure. So this is a patient to really watch out, because now they can develop unexplained jaundice because of that impairment or disruption of his hepatitis B treatment. So they need to watch the patient closely. And if they develop any future suggestive of liver disease, then it's the hepatitis B that's likely to be flaring up, and it can give you fulminant hepatic failure. So this client would benefit from entecavir, because you can use it in addition to this particular regimen as an anti-hepatitis B therapeutic agent. So I guess maybe they can reach out and we can see how to help the patient.
Okay, I hear Dr. Nazila is online. I don't know if she can hear us, maybe to answer the question on the MOH diagnostic capacity.
Good afternoon, everyone. Thank you, Dr. Juma. Yes, I'm online. Yeah, so with regards to what the program is doing, we noticed that we have been actually treating hepatitis as hepatitis C in the key populations program, and hepatitis B in the PMTCT program. And therefore, the focus was really, the hepatitis response and programmatic response was actually
sorry, Dr. Nazila, you dropped off.
Overshadowed due to the HIV. Can you hear me?
Yeah, I can hear you now, but like the past few seconds, we missed what you said. You can repeat.
Okay. I was just actually giving an overview of the program as well as I answer the diagnostic issue. So I was just mentioning the reason why viral hepatitis and STI program was actually formed in NASCOP, so that we can have a focal person to be there to ensure that viral hepatitis and STIs is captured and not forgotten in the HIV space. And that's how the viral hepatitis and STI program came into being in August last year. So we are just almost 1 year old. And just as Dr. Maritim had responded earlier, we were tasked to come up with a committee of experts, which we did, nominated by the Director General at the Ministry of Health, to be able to, guide the programming of viral hepatitis. And so far we have met as the technical working group with the experts, and we are also one of our tasks, our major tasks, is to actually update our 2018 guidelines, which are now outdated, and with the recent updates from WHO and our own local contexts, we shall be able to, to update the guidelines, and therefore those discussions are ongoing, and very soon we shall be having our
Sorry, Dr. Nazila, you dropped off again.
Give me a second, please.
All right, all right.
Yes, I hope I'm now audible.
Yes, you are audible. Yeah.
Yes. Yeah, so currently we are working at updating our viral hepatitis guidelines. And once that is done, we shall come up with the healthcare worker training manual and ensure that all healthcare workers are trained on the new updated guidelines. Of course, there are challenges right now that we are noticing, that the screening is a problem because of the commodities, the PCR, the treatment. And so we are trying to streamline all these cascades so that we are able to reach out to all the patients with hepatitis, and also ensure that all the healthcare workers are well informed onto, how to go about it, because sometimes we get a lot of inquiries from our healthcare workers on what to do. Now, this is the patient, so what do we do? Where do we get the drugs? We have shared the guidelines. I know the 2018 guidelines, although they have been there, the healthcare workers are not aware of their existence. And so therefore, just the program being there and having a focal person ensures that the viral hepatitis is actually covered and it's not forgotten. Even in the discussion which we are currently having in the integration and sustainability conversation, viral hepatitis and STI is actually captured by the mere fact that we are present in at the program level. I know currently in NASCOP, we are dealing with the hepatitis C in the key population program, and hepatitis B is a big agenda in the PMTCT triple elimination program. So therefore, as Dr. Maritim has had mentioned earlier, maybe in the next World Hepatitis Day, we shall be having a different conversation where healthcare workers are now aware that there is this program at NASCOP level, which is dealing with all matters viral hepatitis. So thank you very much, and over to you, Dr. Phoebe.
Thank you, Dr. Nazila. So we'll continue with the Q&A. Maybe if there are other questions, I'll direct them to you. So the next question to Dr. Maritim, what happens if hepatitis B surface antigen is lost in the course of treatment for a patient who met the eligibility criteria for drug initiation based on ALT or DNA or APRI? So they're saying, I foresee patients being on long-term therapy despite acquiring immunity along the way. So do you keep checking for hepatitis B surface antigen or surface antibody after you start treatment, I guess?
Can you hear me?
Yes, I can hear you.
Oh, okay, because I've lost my screen. So when you're treating the patient, you will not use, I did not talk that you'll use hepatitis B surface antigen to monitor. I think I never mentioned anything like that. It's almost like treating your HIV patient and then monitoring by repeating the HIV test. And we always hear where people went for prayers and then they repeated a test, it was negative, and they said, now they have been cured. So hepatitis B virus is a DNA virus. The DNA virus integrates into the hepatocyte. So the only way to really confirm that that patient is cured is to look for the core antigen in the liver. Take a liver biopsy, look for the core antigen and find out that it's negative, that it's no longer there. Then you'll truly say that that person is cured of the hepatitis B. So you're not going to use a surface antigen to say that that person is cured. If you interrupt the treatment for that patient, the hepatitis will wake up, it will flare up, and you're likely to lose that particular patient. So in terms of monitoring, you'll be you'll not use a surface antigen. If you're done the DNA, you can quantify the DNA and see whether it has reduced in terms of the amount for that particular patient. So in terms of hepatitis, unlike hepatitis C, let me just provide a contrast. Hepatitis C virus is an RNA virus. When you treat, you actually are able to cure the person because it's an RNA virus. You can eradicate the hepatitis C from the body. But for hepatitis B, you're just reducing the levels to levels that are low, that they may not be detectable, but that person remains positive for life. So you'll not be monitoring and repeating the test and saying now you want to interrupt the treatment for the patient.
Okay, thank you. So the next question is about the availability of slides. For that, the slides are available on the KNH website or YouTube channel. The next question is about treatment. Treatment recommendations for, or I think so you answered during your presentation, because they're asking treatment recommendation where hepatitis B viral DNA, the E antigen, even liver function tests and platelets are not available. What do you do? And then the criteria for discontinuation of treatment.
Which I spoke about already.
Yeah.
So we said you will not discontinue the treatment. Again, you're using this simple non-invasive test to make a decision. And we talked about the things that you'll make consideration in terms of the non-invasive test and presence of fibrosis. You looked at the presence of the viral DNA plus ALT, comorbidities, and then even just persistently elevated ALT. I think we already spoke about that, and it's available in the presentation.
Okay, thank you. So someone is asking, what is the difference between offering prophylaxis and starting prophylaxis? And it's just language.
Yeah, it's semantic. It's language. It's language.
Okay, so someone is asking about case 4. How long, what will be the duration of treatment for case 4?
Indefinite. Because remember, this case 4, despite being asymptomatic, already has evidence of fibrosis. When we calculated the APRI score, it was high. When we calculated the FIB-4 score, it was high. So this one will treat indefinitely.
Okay. I think the other questions you've also answered, they're like repeats. Someone is asking again about the duration of treatment. So this question, I had a patient come in at 34 weeks gestation with a positive hepatitis B surface antigen. So they're asking, do we still start or is it too late?
No, start. So recommendation is to start as early as 28 weeks. Some school of thoughts even recommend as early as 24 weeks. So initially the fear was if you give the mother tenofovir, then they can have the toxicity of tenofovir. But remember, we are using tenofovir even in HIV space, and we give it earlier, even before conception. So if you start at 34 weeks, depending, and in this case, you're not able to do the viral load, so you won't know, but it's better to start than not to avert that infection transmission. So 34 weeks is not too late. Just go ahead and start. And remember, you're going to give it up to 12 weeks postnatal.
Okay, so there's a question here. Someone is asking you like to foresee the future. So they're saying, lastly, with evolving evidence, do you foresee a test and treat strategy, just like what happened in HIV?
Yeah, I think that's a very good question. I feel, this is now my own personal opinion, I feel like the hepatitis program can really benefit a lot from the gains that we've learned and then the learnings that we've learned from the HIV program. Because we are talking about things that we are doing in the HIV program. We are talking about prevention of mother-to-child transmission, where you're using single-dose nevirapine. Then we went now to treating pregnant women with a CD4 count less than 350, then increased to 500. Then now it's test and treat for everyone. So it's the same thing that we are saying. You are having this hepatitis B that you can give prophylaxis to the mother to prevent transmission. But eventually, we'll probably reach that point where you'll be testing everyone and treating. So the main thing, I think, is really the funding of the program. How will we fund the viral hepatitis program? Because as it is now, the clients are getting their treatment now through the HIV program. But we need to have a more sustainable way of funding the program before even we can envision a test and treat strategy. So I think this is, as you say, the future is there and it's dynamic, and we may actually reach that phase of test and treat. But I think we are headed there. Just in summary, we are headed to that test and treat. For now, it's just prioritization and giving treatment. And I think the most important thing is for us to reflect. We've been giving the hepatitis B vaccine since 2001, 2002 in the national program. We need to do a quick audit and just see what's the magnitude of, for example, hepatitis B infection in children who would even have been vaccinated, because that way we are able to account for things like the lack of the birth dose, because then we were not able to mitigate those infections. So I think even the success of the hepatitis B program, vaccine program, would have reduced significant numbers, especially if you're giving a birth dose of hepatitis B, because then we'll be really blocking that mother to child transmission. And because you're giving it to an entire birth cohort of about 1.5 children every year, it would mean that over the last 20 or so years, we should actually have been doing away with pediatric hepatitis infections. So we need to reflect and see and audit just that vaccination program and see what are the gains that we've made so far. Is it that the older populations have the hepatitis and the younger populations are free of hepatitis? And I think that's the kind of data even the technical working group will be looking at as they inform the future in terms of the hepatitis guidelines for the country. But I think this is one program that gives us so many interventions. We have the vaccine, we have the oral antivirals, and then we even have the antivirals to treat the infected population. So I think there are many things at play that we can count on.
Okay. So this one, the next question is more of a clarification. So they're asking, is the treatment with tenofovir offered irregardless of the HIV status?
Yes. So it is offered regardless of the HIV status. And that's why I think my opening statement is that when we have a HIV co-infected person, the decision-making process in terms of whether to treat or not to treat is not there, because the current treatment that we're giving for HIV takes care of the hepatitis B. So actually the focus of my lecture was treatment of hepatitis B or management of hepatitis B in the HIV negative population. So the treatment with tenofovir is regardless of the HIV. Tenofovir is the drug that's recommended for treatment of hepatitis B, even in the HIV negative person. I hope it's clear.
Yeah, yes, it's clear. So if the next question, if a pregnant mother has hepatitis B and is on treatment, is there a need to vaccinate the newborn?
Or repeat the question, sorry.
If a pregnant mother is found to have hepatitis B and is on treatment, is there a need to give the newborn hepatitis B vaccine at birth?
Yeah. So the decision to vaccinate the birth dose with hepatitis B will be given to the entire birth cohort, irrespective of the mother's status. So when you look at public health interventions, you don't give interventions selectively. Maybe if we are resource constrained, then we can say we'll only prioritize the mothers who are hepatitis B positive to vaccinate their children. But you're talking about a birth dose of hepatitis B to be given to the entire citizens of children born in Kenya. So even if the mother is on treatment for HIV, the reason for the birth dose is that you want the baby to develop their own active, like you have two forms of immunization: passive, where you're giving immunoglobulins, but active is where the baby is developing their own antibodies. So you want the baby to develop their own antibodies to protect them against the hepatitis B. So vaccinating the baby is regardless of even whether the mother is taking treatment or not, because when you have the two interventions working together, so the mother's treatment will reduce the viral load significantly, but also the birth dose of hepatitis will help the baby to develop their own immunity against hepatitis B.
Okay, so the next question. Thank you, Dr. Maritim, for the great presentation. I'm just wondering about the discrepancy in initiation of antiviral treatment. So in pregnancy, the cutoff is 200,000 international units per mil copies, but whereas in the other populations, it isn't. It's indicated as 2,000. So they're wondering why that discrepancy.
Oh, so the discrepancy is there was a slide. Maybe if you pull down your slide, Phoebe, the slide or Mwendwa, this slide that is showing. Yeah, I can project the slides back again. So from clinical trial, not really clinical trials, epidemiological studies and other evidence, like the threshold for risk for infectivity for the mother to child transmission is highest for 2,000. So when you're making the decision in terms of maternal prophylaxis, if the maternal prophylaxis is more than 2,000, because maternal prophylaxis is a time-bound period. You're giving from 28 weeks to 12 weeks postpartum, and you'll stop that treatment. And therefore, if you have been able to quantify and you find that it's 200,000, then you're able to offer the maternal prophylaxis. I'm just trying to share my screen, or just 1 minute. We have to open it first. Just give me a minute.
Okay.
Now I've lost my webinar screen.
Uh,
So, okay, but maybe I can just, since I've opened it and I'm not able to load it. So mother seropositive for hepatitis, I'm just reading it from, this is slide number 19. So mothers seropositive for hepatitis E antigen. Remember, E antigen was the one that is a marker of infectivity, or who have a high hepatitis B viral DNA level in blood, more than 200,000 international units per mil, are at highest risk of transmitting the infection to their infants in the absence of prophylaxis. So if you're able to quantify for mothers particularly, then you're able to make that decision, because for these mothers, you can actually offer them the prophylaxis, and because it's time bound, you're able to make that particular decision. The other consideration we're making is particularly for people who have evidence of fibrosis and existing disease, meaning, so maybe I didn't bring it out clearly. When you have hepatitis for long, the presence of the hepatitis B causes fibrosis, and the longer you are with the hepatitis B, you actually move from E antigen positive disease to E antigen negative disease. So although your hepatitis E antigen will be negative, but at that point, you are likely to have already established clinical consequences of presence of the hepatitis B virus in the form of fibrosis. So when you're making the decision of the in terms of treating the person, you're more interested in terms of the fibrosis, in terms of long-term treatment, because then you can influence, you can have an impact on the fibrosis, or reversing or retarding the fibrosis by presence of treatment for the hepatitis E. So for the mother, this viral load quantification is really for decision-making around preventing that transmission to the baby. And that's why, in the absence of availability to do that quantification, then you'll offer the tenofovir prophylaxis to all mothers who are pregnant. I hope I've answered the question. So the quantification is to distinguish the magnitude of that burden and the risk for transmission. So mothers who have this high viral load are likely to transmit the infection to the baby. And that's why that specific criteria is indicated for the mothers. But in the general population, you're expecting that this person maybe has been with the virus for so long, you're meeting them at just one time point. So even you're more interested in determining the fibrosis, which is a long-term sequelae of having lived with the virus over a very long period of time.
Okay, thank you. So I think we are 7 minutes over time, so maybe I'll just take a few more questions. I think there are so many. I'll just take a few, like 3 more, and then we can wrap up. So the next question, I don't know, may not be a bit fair because you're management of adults. So they're asking about management of hepatitis B in pediatrics, those who are under 12 years.
Yeah, that one,
The
yeah,
management.
I'm not, yeah.
Okay.
That one, yeah.
All right. So the next question is about the hepatitis B vaccine. So they're asking, how long does hepatitis B vaccine last after you get the 3 doses?
So it's supposed to be lifelong, but other schools of thought actually recommend boosters like every 10 years. In our current guidelines, we give the 3 doses at birth, and there could be things that interfere with even the uptake of the vaccine. So I'm not sure that I'm able to really fully answer that question. But in other settings, like if you look at the US guidelines, they actually recommend that you should get the 3 doses, so times 0, 1, and then 6 months later, and then actually get a booster after an interval of 10 years. So in our setting, we just recommend the 3 doses, which we hope that will be able to offer protection for life. But we need to maybe conduct studies to really see the immune profile in terms of, for many of us who are already vaccinated, whether this protection is actually for life. And then another thing, while I'm still at vaccination, so when you give the birth dose, and then you give the other 3 doses, in terms of even counting, you don't say the birth dose is the first dose. The first dose is actually the one that you give at 10 weeks. The second dose is at 14, sorry, the first dose will be at 6 weeks. The second dose is at 10 weeks, and then the third dose will be at 14 weeks. So the birth dose is denoted specifically as birth dose, and then first dose is 6 weeks, second dose is 10 weeks, and then the third dose is 14 weeks.
Okay. So the next question is on monitoring. So they're asking for those patients who don't qualify to start treatment. So now, how frequently do we monitor the ALT levels and the hepatitis B DNA?
So for this one, I think I've been able to locate my slides. Let me just share, because it was actually in my presentation. Just allow me. I'll just remove the screen that is showing now so that I can share. I'm not able to see my sharing button, or I'm seeing it. I've seen it. So this was actually in terms of monitoring. Can you see my slide? Let me put slide presentation. You will be monitoring for treatment progression, even for the people you did not put on treatment. So you'll be monitoring every 12 months, that's every year. For the ones who are on treatment, you'll be checking the adherence at each visit. If they're not on treatment, then you'll be checking the APRI score and the transient elastography. You'll also be monitoring the ALT and hepatitis B viral DNA. For the ones who are on treatment, you'll be monitoring the renal function. So it's every year. This was in my presentation. There's another slide that I've also included that I didn't have before. Sorry, let me look for it. And I've seen it in the Q&As recurrently. The treatment. So this is a treatment for hepatitis B. You have tenofovir, which is TDF. Then you have entecavir, and then entecavir again for those ones who have decompensated liver disease, and then tenofovir alafenamide. Because what has been asked is about the dosing. When you're giving tenofovir, your dosing is based on, will be guided by the renal function, sorry. You'll be able to make a judgment in terms of the dosing. So if the creatinine levels, then you have to be able to make adjustment. But unusual dose of tenofovir is 300 milligrams once daily. If you're giving tenofovir alafenamide, you're using a smaller pill. It's 25 milligrams once daily. So when the creatinine is less than 10 mils per minute, like in that case that we were asked earlier, for the patient who's on hemodialysis who has end-stage renal disease, you can actually use tenofovir every 7 days or 1 300 milligram tablet following the completion of every 12 hours of dialysis. So again, you're able to dose and adjust, because remember, your patient needs the tenofovir for the hepatitis B, even though they may not need it for the HIV. You've already put on abacavir, but you can be able to do the renal dosing. So this chart is able to really provide a guidance in terms of the dosing of the tablet, as well as even the adjustment of the treatment based on existing renal impairment, depending on the levels of creatinine clearance. So I just wanted to speak to the monitoring, where you're monitoring once a year, and then in terms of the treatment, how you're treating. I hope it's clear now.
Yes, I think it's clear. So I think the last question, they're asking, discuss something about pegylated interferon. I don't know whether it's available locally.
So when you read the latest WHO guidelines, the role of interferons have sort of been relegated to, I think, when we were in undergrad and even when we were starting postgrad, they were important in treatment of hepatitis B. But at that time, these drugs were under clinical trial. So currently, their role in terms of treatment for viral hepatitis, because of the cost and the fact that you have to inject them, they make them really, really out of reach for patients who have hepatitis B, and also there are safety concerns, but more so the cost. So interferons are drugs that you have to inject, and you have to, they're very costly. At the time when we were in undergrad, I think a dose was 1.2 million. I don't know what's the current price for the dose, but when you have these newer drugs, they're actually more affordable. They are more easily available. And given the data that I showed you at the beginning in terms of public health intervention for treatment of hepatitis B, it makes more sense to use drugs that are easily available, easier to take, more affordable, because then you can think of designing a public health program where you can be able to reach far more individuals. So I think we can all read up the literature of interferons, but for now, when you look at the WHO guidelines for 2024, they actually recommend using the oral antiviral agents, of which tenofovir, the two forms of tenofovir, TDF and TAF, are in that list. So that's all I can say.
Okay, thank you. So I think that's clear. The questions are so many. I think there were like more than 90 plus 99 on the chat. So we're not able to get to every question. We are like 15 minutes over time. So I think Dr. Mariti, maybe if you have a parting shot, I don't know if Dr. Nazila is still on the call. You can give a parting shot after as well.
So myself or Dr. Nazila first?
I think yourself first.
Oh, okay. So I think as my parting shot, when you look at this new guidance and the fact that even in the Kenyan space, we are at that point when we are revising the guidelines, it makes it much more easier to make a decision around the patients and to cancel the patients appropriately, to see where treatment is indicated and to offer the treatment. For the pregnant women, I think it's more urgent, because in terms of preventing mother-to-child infections. That is really of more importance and more significance, because we know that children who get infected in their early life are likely to develop chronic infections. And by their second and third decade, they'll actually be having hepatocellular carcinoma. So we need to screen pregnant women. We need to offer prophylaxis, and we need to really prevent hepatitis B mother-to-child transmission. So I'm urging all of us at least to play our part, to play our role, even as we prevent infections for the people we look after. And remember again, hepatitis B, the person will not have jaundice. It may be a symptomatic infection. The only thing that can help us is screening tests, and we need to do more in terms of screening and offer an intervention. And hopefully what we've discussed today can have an impact in terms of reducing infections, and even for the people who already have infections to be able to get treatment. I think when I was even preparing this presentation and reflecting on the cases, some of the cases of people I'd reassured and told them they don't need treatment. Now, with these new guidelines by WHO, they actually, many of them would qualify to receive treatment. So the issue is really making that decision in terms of treating now or monitoring and waiting in terms of, especially if a patient is maybe young and you are worried about the risk of long-term toxicity because of tenofovir TDF specifically. But thank you so much for this opportunity to come and present and share experiences.
Thank you. Dr. Nazila, any comment?
So first of all, I'd like to thank Dr. Maritim and yourself for this excellent presentation. We are really thrilled and happy that, you know, at least as we move to commemorate and celebrate World Hepatitis Day, we're having this webinar, which is very informative to everyone, the healthcare workers as well. And just to let everyone know that the viral hepatitis and STI program is now fully functional under NASCOP, and we can be reached at vhsti@nascop.or.ke for any probably questions, clarifications, or for anything that the healthcare worker out there may need in terms of viral hepatitis, and that we in viral hepatitis space are there so that we can be present in all the conversations and ensure that we also ride on the HIV space so that we are not left behind. Yeah, and we are working to update the guidelines, and very soon we shall then update everyone on where we are at and what the new guidelines are all about. So thank you very much, and over to you.
Okay.
One more thing, we are commemorating and celebrating the World Hepatitis Day in Baringo County on Friday. That is the day after tomorrow, on 26th, at Marigat Sub-County. So, karibu sana, all are welcome. Asante.
All right. Thank you very much. Thank you, Dr. Nazila, Dr. Mary Beth, and thank you to the audience. Those were really great, tough questions that you asked. Just to remind you of our slogan for this World Hepatitis Day, it's time for action. So make sure you're tested. And for those who've been tested and you're positive, screen for whether you need to receive treatment. So thank you all. And that's it. We'll see you the next time, the next presentation. Good day.
Thank you, Dr. Phoebe.
Thanks and bye.